Uh, I'm going to speak on year in review. Basically, the talk given to me on hemodynamic monitoring. But what I have done is I have selected 6 papers which are related to monitoring, and if we get a time, I'll talk on the 7th paper which is related to therapy. Now, my first paper is the use of central venous pressure measurements improve the accuracy of leg raising induced change in pulse pressure to predict fluid responsiveness. We know that after initial phase of resuscitation, the static measures of the filling pressures do not predict the response to volume expansion. And for this matter, and sometimes they can be deleterious. So now we have developed some dynamic indices, and one of them is a response to passive leg raising, which is found to be quite useful. Because it is simple and safe due to reversibility, it mimics the volume expansion by shifting the fluid from lower leg capacitance vessels towards the intrathoracic compartment. That causes the increase in the left and right ventricular preload, and this then increases the left ventricular stroke volume and cardiac output if the patient's ventricle work on the ascending portion of the Frank-Starling law. So this study design was basically a prospective multi-center study, and the aim of this study was to assess the influence of passive leg raising induced changes EVP on the performance of the change in the pulse pressure and the change in the cardiac output for the prediction of fluid responsiveness. And basically the authors devised this study because recently there have been few studies which have started raising the issues about the passive leg raising, that it does not detect all the time the patients who are the fluid responsive, and they are trying to look at what are the causes. So basically the inclusion criteria was adult patients undergoing volume controlled mechanical ventilation without triggering the ventilator with the evidence of acute circulatory failure in the form of blood pressure lower than 90 millimeters of mercury, mean blood pressure less than 65, skin mottling, less urine output, increased arterial lactates and vasopressor infusion but without arrhythmia. And they excluded the patients who had diuretic treatment, uncontrolled hemorrhage, brain death, leg amputation, phlebitis, compression stockings, IABP, and the study procedure was stopped in case of changes in respiratory settings or vasoactive therapy or the occurrence of arrhythmia. Now, what it actually involved was they took the readings, the baseline when the patient was flat, then they elevated the legs to 45 degrees, that's the 45 degrees passive leg raising test. They again brought the patient to the baseline, and then they induced first 300 ml over 18 minutes to see how the patient tolerates, and then another 200 ml over the next 12 minutes. And they took the readings at all 5 settings. And these measurements basically were invasive blood pressure, heart rate, saturation, CVP, pulmonary artery occlusion pressure, total PEEP, and cardiac output. The cardiac output was measured through either the pulmonary artery catheter or the PICO if the patient had, and they calculated the change in the pulse pressure and cardiac output induced by the passive leg raising and then after the volume expansion therapy. After volume expansion, patients were classified as responders if cardiac output increased by more than 10% and as non-responders otherwise. And for each index, then they calculated the area under the curve of the receiver operative curve. Now, if you look here, the main patients were the septic shock, almost 50% patients, and 92% of the patients in this group were receiving the vasopressor therapy. Now, if you look at this, what they have done is they have looked at the patients at 3 stages, the baseline CVP, responders and non-responders, and then retrospectively they have gone back and seen what was the increment in the CVP after they did the passive leg raising test. And if you see it over here, the mean arterial pressure that I have red marked basically because after the passive leg raising test, in the non-responders also you can see that there is a increase in the mean arterial pressure, which they really could not explain. But to tell you the point that even after passive leg raising, why your mean arterial pressure is not a good indicator, because that does not necessarily correspond with the raise in the cardiac output. So arterial pressure is not a good indicator. You have to see the cardiac output or pulse pressure variation when we are doing the passive leg raising test. And for the responders, when they looked at the increment in the CVP, the patients who did not get the increment in CVP of more than 2 really did not discriminate the patients who will respond to the fluid infusion or no. And that is because probably the infusion that we give by causing the passive leg raising may be inadequate to actually challenge the heart, and this patient, even if he is responsive to fluid with the passive leg raising test, may not show that he is a fluid responsive. So if along with that we look at the CVP, that if I do 45, the CVP goes up, this patient will be able to tell us whether the patient is fluid responder or not responder. But if your CVP does not increase by 2, then it's really not good to discriminate between the patient who will respond to fluid infusion or not. Now the second paper is published in Critical Care Medicine 2010, which looked at the passive leg raising is predictive of fluid responsiveness in spontaneously breathing patients with severe sepsis or acute pancreatitis. Now, recent studies have demonstrated that initially we said that the passive leg raising, all these dynamic measures were useful in the patients with a controlled mechanical ventilation. But the recent studies have demonstrated that it can be used in the patients to look at the volume infusion responsiveness, whatever the breathing condition. So even we can use it in the spontaneously breathing patients. And these authors hypothesized that the passive leg raising test and the response to it would be equally good or the predictive of the volume expansion responsiveness in the patients who are also spontaneously breathing. And another aim of their study was to test whether the stroke volume, pulse pressure variation, and the velocity in the femoral artery are equally accurate at predicting the volume expansion responsiveness in non-intubated patients with the acute circulatory failure. So this was a prospective observational single center study which was done in a 21-bedded ICU over 18 months. And the inclusion criteria were all non-intubated patients with sepsis or acute pancreatitis with no amputation of lower limbs for whom the attending physician decided to perform the fluid challenge. The patient had to be in regular and sinus cardiac rhythm. And the exclusion criteria were high-grade aortic insufficiency, poor echo window because they had looked at the aortic blood flow as a gold standard, and need for invasive ventilation. Now, the fluid challenge decision was based on the presence of at least one of the clinical signs that we had seen in the previous paper, the same clinical signs they had taken for the circulatory insufficiency, and every patient had 3 French radial artery catheter in place before the study as part of their standard hemodynamic monitoring. They measured the systolic arterial pressure, the mean arterial pressure, and the pulse pressure. They looked at the aortic blood flow with pulse Doppler at the level of aortic valve. They also measured the femoral blood flow with continuous Doppler at the level of common femoral artery to look at the changes in the femoral artery flow velocity. And because hemodynamic values may vary within a respiratory cycle, an average of 10 consecutive cardiac cycles or at least 1 respiratory cycle was used. Now, their study design was slightly different, and these authors called them as a modified passive leg raising test in the sense that their patients were initially in the head high position. So, they took all these basic measurements in this position, what they labeled as a baseline position. Then they made the patient the reverse way. So, what they said that after making the patient flat, you get some amount of fluid coming, and then when you raise the limbs to the 45 degrees, you get more. So rather than making the patient who is supine, elevating the limb to the 45 degrees, the amount of fluid challenge that it does, this gives much more fluid challenge. And they took the readings at the baseline, then when they did the passive leg raising, then baseline 2 when the patient was brought back to the previous position, and at this position they gave the volume expansion using 500 ml of infusion of 6 Hitastarch. They labeled responders where you got the volume expansion, induced change in the stroke volume of more than 15%, and otherwise they were labeled as non-responders. This study was done in 890 admissions. They found 39 patients who met the study criteria. The 5 patients were excluded for poor echo window because they could not look at the aortic flow, and 34 were included in this study. And when they looked at the correlation, the best correlation they found was obviously with the stroke volume variation, which is the gold standard, but they found an equally not so good but good correlation using either the velocity at the femoral artery or the pulse pressure variation. And when they calculated the sensitivity and specificity for this, they found the best sensitive specificity was for the stroke volume variation, but the pulse pressure variation and the change in the femoral artery flow velocity was quite good. So saying that we can interchange so the patients who do not have a good echo window where an echo cannot be performed or the aortic flow cannot be seen, one can use simply the femoral flow, femoral artery velocity, which is easier to perform and does not need a good echo window as an interchangeable measure to look if your patient is volume responsive. And when they plotted the receiver operative curve, with the best area with the stroke volume variation but equally good with the femoral artery velocity or the pulse pressure variation. Now, the limitation of this study was obviously it was a study which was single center. There was a small number of patients, and they had excluded the patients who had got left ventricular or the right ventricular dysfunction. So you cannot apply this study in that group, but the patients who have got good heart function, definitely one can use the femoral artery flow velocity as an alternative for looking at the aortic blood flow. Now, the third study is the influence of the airway driving pressure on pulse pressure variations as a predictor of fluid responsiveness. Now, we know that the basic physiological funda behind doing the fluid challenge test in the patient on mechanical ventilation is that when we do the positive pressure ventilation, it increases the pleural pressure, which decreases the venous return and decreases the cardiac output. So by giving the positive pressure, we are looking at the pulse pressure variation, and more is a hypovolemic patient, more would be this pulse pressure variation. But with the ARTSNet protocol coming in, now we have started restricting ourselves to low tidal volume and low plateau pressures, which does not give a high variation in the interpleural pressure. So the objective of this study was to assess the pulse pressure variation to predict the fluid responsiveness in mechanically ventilated patients and the impact of tidal volume and airway driving pressure. There is a difference between the plateau pressure and PEEP on the ability of pulse pressure variation for predicting the fluid responsiveness. This was a prospective interventional single center study in the ICU of University Hospital. Patient selection was 57 mechanically ventilated and sedated patients with acute circulatory failure requiring cardiac output measurement. The sedated and mechanically ventilated ICU patients without spontaneous breathing with acute circulatory failure, and they had defined the acute circulatory failure as what we had seen in the previous criteria, along with those patients who are requiring vasopressors, either epinephrine or non-epinephrine, and a systolic blood pressure to maintain the systolic blood pressure of more than 90. The inclusion criteria is the patient had to have a monitoring of cardiac output and cardiac index, need for fluid challenge due to signs of hypotension which was left at the discretion of the primary physician, and the exclusion criteria were patients with cardiac dysrhythmias, known tricuspid insufficiency, obvious impaired ventricular dysfunction, moribund patients, pochurient, and patients less than 18 years of age. The fluid challenge was given intravenously at a constant rate of 1000 ml per hour. 250 or 500 ml of isotonic saline or HES was used, and the fluid responsiveness was defined as an increase in the stroke volume more than 15%, separating the study population into responders and non-responders. These are the patients' population. They had total 57 patients which were included in the study. And when they looked at it, you can see the pulse pressure variation more than 13% was found where you had a larger driving pressure. There's a difference between the plateau pressure and the peak. So in this case, the pulse pressure variation of more than 13% could discriminate the patients who are fluid responders versus non-responders. But the pulse pressure variation of 7 to 13% was found in the patients who had a lesser driving pressures. And if the patients were further, the less than 7% really could not differentiate between the patients who would respond or would not respond. And based on this study, the authors have suggested that in these patients where we have got a less driving pressure, probably we should keep the threshold of pulse pressure variation as 7%, where it will be able to discriminate more responders, again non-responders. And in this subgroup of patients, the pulse pressure variation negative does not mean that this patient would not be responding to fluid, and one can still go ahead and give the fluid based on their data of 57 patients, where they said in all these patients by giving the 500 ml of fluid, no patient developed respiratory failure. And when they looked at the analysis, the only two factors came as clinically significant was the tidal volume. So larger is the tidal volume, more is the discriminating power, or the larger is the driving pressure, more is the discriminating power. Okay, so these three were based on the PLR, which is telling, basically the inference of these three studies are telling us that we can use the PLR, the passive leg raising test in the patients who are spontaneously breathing. We can use the femoral flow velocity to look at the change in the patient's cardiac output. If we want to look at the PLR, if we have got the central line in place, then if we get the increment of CVP of more than 2 centimeters of water after doing PLR, and then we can better discriminate between the responders or non-responders. But if we do not get that much of increment in CVP, it's really not telling us whether we have challenged the heart adequately or no. Now, next three papers are basically based on the guided therapy or the goals. This is the study which was published in American Journal of Respiratory Critical Care Medicine, where the early lactate guided therapy in the intensive care unit patients. This is a multi-center open label randomized control trial. And the rationale of this study was, we know that the increased blood lactate levels have been associated with significant morbidity and mortality. Nevertheless, it is unknown whether monitoring of lactate aimed to decrease levels during initial treatment in critically ill patient improves outcome. We know that the reverse study had looked at the SCVO2 as a goal when resuscitating the septic patients in the early stage. So these authors looked at the lactate as a goal while resuscitating the patients in the sepsis. So the primary objective of this study was to test whether patients with elevated lactate levels, that's more than 3 milliequivalents per liter, on ICU admission would benefit from serial lactate monitoring aimed to reduce these levels by 20% per 2 hours when compared with patients in whom the serial lactate monitoring was not available. And the secondary objectives were to look at the effects of lactate monitoring on the development of organ failure, the duration of mechanical ventilation, use of inotropes, vasopressors and renal replacement therapy, and the length of ICU stay. So this study was done in 4 Dutch mixed ICUs, which were the university hospital and 3 were university affiliated hospital over 2 years. The inclusion criteria were all consecutive patients with a blood lactate level at or above 3 milliequivalents on ICU admission. And the exclusion criteria were patients with liver failure, liver surgery less than 18 years, contraindication for central venous catheterization, epileptic, and the DNR status. Now this was a multi-center open-label randomized controlled trial. And because of the emergency nature and severity of the disease, patients were enrolled under deferred consent. All the ICUs were the closed ICUs, which were manned by qualified intensivists for 24 hours, 7 days a week. The treating physicians were primarily responsible, and they had divided the study into 2 groups, the 8-hour study of the treatment, and then it was an observation period. So after 8 hours of the study period, both groups received the same treatment, during which lactate levels could be obtained in all patients at the discretion of the treating physician. Now this is their schema. The patients who came with the lactates more than 3 milliequivalents per liter were stratified and stratifidly randomized into the group which was control group or the lactate derived group. They received the 8 hours, the control group received the 8 hours of non-lactate directed therapy, as against the lactate group received 8 hours of lactate directed therapy. And their goals were the same, the mean arterial pressure, to maintain the mean arterial pressure of more than 60, heart rate of less than 100, the CVP of 8 to 12 millimeters of mercury for spontaneously breathing, and 12 to 15 for the patients in the controlled ventilation, urine output of more than 0.5 ml per kilo per hour, hemoglobin more than 7, arterial saturation more than 92, and the advanced monitoring was allowed if they wanted in the form of SCVO2 but not lactates. Whereas in the lactate-directed therapy, they had the same goals to achieve, so they resuscitated for the same goals, but along with these goals, they also had to get the goals of decreasing the lactates or aiming to decrease the lactate by more than 20% per 2 hours. And after this 8 hours of treatment group period was over, then started the observational period where they collected all the data that they wanted to have. Now in the lactate group treatment, the study protocol was, when you got the lactates more than 3 milliequivalents per liter, the patient was enrolled in study, and when the patient went for the lactate directed treatment group, they had the SCVO2 measured. So if the SCVO2 is more than or equal to 70%, and still the lactates are high, that means probably this patient has got the microcirculatory derangement, and these patients would receive vasodilator in the form of NTG or ketanserin. If the SCVO2 was less than 70%, they look whether the patient was fluid responsive. If the patient was fluid responsive, it is hypovolemia, patients received fluids. If the patient was not fluid responsive, that means a fluid challenge test was non-responder, it was diagnosed as having a myocardial dysfunction, and these patients were started on inotropes, either dobutamine or enoxaparin, until the SCVO2 went above 70%. If the patient's SaO2 was less than 92%, that is arterial saturation, hypoxemia, and their oxygenation was increased with the use of increased FiO2. If the hemoglobin was less than 7 gram%, the patients were given the packed cells to get the hemoglobin of 10 gram%. And if the patient had pain or agitation, it was obviously the lactates, or because of increased oxygen demand, so the patients received analgesia, sedatives, and the cooling. But ultimately, their aim was to get the lactates after 2 hours. The decrease in the lactate should be more than or equal to 20% at the end of 2 hours. If they achieve that goal, then you continue the patient with the therapy. If they did not achieve the goal, you go back, find out what is the cause, and start the treatment. So this was totally a lactate deciding how you are going to manage the patients. Now in this, the primary endpoint was in-hospital mortality, and the secondary predefined endpoints were ICU and 28-day mortality. Now at the baseline, both the groups had the same characteristic in the form of age, the diagnostic category, and their severity of illness. And surprisingly enough, those patients, even they did not receive the lactate guided therapy in the control group, both the groups had the same lactate levels when they looked retrospectively. But the difference was in the treatment that they received. So in the first 8 hours, the lactate guided group had received more fluids as compared to the control group and the vasodilators. So the lactate guided group received more fluids and more vasodilators. It's half an hour, right? Yeah, it's a 30-minute session, please. And when they looked at the mortality, the unadjusted mortality, it was the trend towards a better outcome in the lactate group. But when they adjusted the analysis for the age and the severity of illness, it definitely found that the ICU mortality and the in-hospital mortality was significantly low in the lactate-guided therapy as against the control group. And this is what their Kaplan-Meier curve showed. And the other difference that they found was at 9 to 72 hours, in the lactate group, the SOFA score was much less or had decreased as compared to the control group. When they looked at their secondary endpoints of weaning, weaning from mechanical ventilation, the group who received a lactate-guided resuscitation were weaned off early from the mechanical ventilation and they're weaned off early from the inotropes. But there was no difference as far as the stoppage of the vasopressors and the renal replacement therapy was concerned. And there was a significantly earlier discharge from the ICU in the lactate group as compared to the control group. When they did the subgroup analysis of the pre-specified groups, they did not find any difference, though it was tending towards a better favorable outcome in the lactate group. In the neurological group, the outcome was worse in the lactate group, and that is probably because the neurological group, more fluids and vasodilators influenced the outcome. In their post-op analysis, they found that the patients who had come to the ICU's early admission, which they considered as 6 hours from the hospital admission, they had definitely a better outcome when they were resuscitated looking at the lactates rather than the late ICU admissions. So showing that the lactate-guided therapy definitely helps in the patient's outcome. But the only drawback of this study was in the lactate-guided group they had also allowed the SCVO2 measurement, whereas in the control group the SCVO2 measurement was left at the discretion of the physician. So there was all patients did not receive the SCVO2 guided what early goal-directed therapy of reverse study had said. Now the second group has looked at the lactate clearance, has come in the JAMA. Lactate clearance versus central venous oxygen saturation as goals in early sepsis therapy, and this was a study which was looking at the non-inferiority study. So goal-directed resuscitation for severe sepsis and septic shock has been reported to reduce mortality when applied in ED. That was a reverse paper which was done looking at the SCVO2. Now at many centers the SCVO2 may not be available, it requires a specialized catheter, one may not be able to put those lines. So they looked at the thing that if you can replace this with the lactate guided therapy, whether it makes the difference or whether it's equal at par. So the objective was to test the hypothesis of non-inferiority between lactate clearance and central venous oxygen saturation as goals of early sepsis resuscitation. So this was a multi-center randomized non-inferiority trial involving patients with severe sepsis and evidence of hypoperfusion. There was non-blinded concealed randomized control trial with intention to treat. The sample size calculation was done, which was around 150 per group. The inclusion criteria were the same, where patient had the high lactates and the patient had evidence of tissue hypoperfusion, and the exclusion criteria were mainly pregnancy, post-CPR, transfer from other institutions, etc. The treatment assignment was randomly assigned using group assignment sequence generated by independent statistician in the sample size of 300 and block size of 10. Each group received structured quantitative resuscitation while in emergency department. So this study was done in the emergency department. The SCVO2 group was resuscitated using the SCVO2 as a goal. So first you have to achieve a threshold CVP, then MAP and then SCVO2, whereas the lactate clearance group had similar target thresholds of CVP followed by MAP and then the lactate clearance instead of SCVO2. And by design, the clinical staff in the emergency department could not be blinded to group assignment. However, the clinical staff which managed this patient later in the ICU did not know about what group this patient belonged to. The dopamine in this study was performed in emergency department. Sequential fluid resuscitation was initiated, aiming for CVP of more than 8 and MAP of more than 65. Dopamine or noradrenaline were used if required to achieve the goals. A septic screen was performed. Interventions were continued until targets were achieved, and the patients were then handed over to the ICU physicians. In the control group, the target was SCVO2 more than 70%, and the experimental group, the target was instead of SCVO2, you look at the lactate clearance of at least 10% at the end of 1 hour. And if the lactate clearance was less than 10%, then the cardiac output was augmented by increasing the hematocrit and dobutamine. So in this, they screened 452 patients, the 300 were randomized, 150 into lactate clearance group, 150 into the SCVO2 group, and they were doing the primary analysis. Now, if you look at the variables of the study, all the blood pressure parameters, heart rate, central venous pressure, CVP, lactates, SOFA score, all were same in both the groups, so both groups were similar. The crystalloid volume that the patient received, the vasopressor, the dobutamine, again same, there was no significant difference in the two groups. And the hospital mortality and the ICU mortality, the ICU length of stay or the other ventilator-free days or multiple organ failure was equal in both the groups, saying that while resuscitating the septic patients early in emergency department, your lactate is as good as using SCVO2, so one can use one if for the other the facility is not there. Now, the third paper in this group is the paper which is common critical care medicine. This central venous saturation is a predictor of re-intubation in difficult to wean patients. Now, we know that to evaluate the predictive value of central venous saturation to detect the extubation failure in difficult to wean patients, the extubation failure occurs in approximately 14% to 32% patients meeting the weaning criteria, indicating that the traditional two-step protocol, that first we evaluate the patient for the ability to be weaned off, and second we give the 30 minutes TP's trial, it fails to adequately detect the difficult to wean patients. And the presence of cardiovascular dysfunction may be a major factor contributing to this. So this was a cohort multicentric clinical study performed in 3 medical and surgical ICUs. The inclusion criteria were all difficult to wean patients, mechanically ventilated for more than 48 hours. And the exclusion criteria was tracheostomized patients, patients with no central venous catheters, negative informed consent, and weaned successfully in the first weaning trial. Now, the protocol was the patients meeting study criteria were weaned in a semi-recumbent position, and you can see that the patients who were mechanically ventilated were eligible for the study. The patients who successfully cleared the spontaneous breathing trial, the patients who failed in the first were included in this study of the SCVO2 to detect the failure to wean. And these patients were then daily given spontaneous breathing trial till they succeeded. Now, once they succeeded, they were extubated. Those who extubated suction and extubation failure, if the patient gets reintubated within the 48 hours. So, these 74 patients were in the group of this study. So, a total of 73 patients, where there are 42 patients were extubation success and 31 patients were the extubation failure. The baseline criteria were the same, but what came out different was those patients who could be successfully extubated, the difficult to wean patients, had SCVO2 significantly higher than the patients who had failed extubation at the end of 30 minutes TP's trial, and obviously oxygen extraction ratio, which was calculated, had gone up. If you look the saturation, the SCO2 was same in both the groups. So what made difference was the patients who had the drop in SCO2. So you can see that the patients who successfully could be extubated had the SCVO2 remain, but in the patients who failed extubation had the SCVO2 drop. And when they did the area under the curve, the receiver operating curve, the more than 4.5% reduction in SCVO2 at the end of 30 minutes of TP's trial was associated with a greater risk of reintubation, that is more chance of the failure of the extubation, with the odds ratio of 49.5. Now, this is my last paper, which is basically actually based on the therapy, which is come in the New England Journal of Medicine, looking at the comparison of dopamine and norepinephrine in the treatment of the shock. And this study's aim was to evaluate whether the choice of norepinephrine over dopamine as the first-line vasopressor agent could reduce the rate of death among patients in shock. This is a multi-center trial with 8 centers in Belgium, Austria, and Spain. The duration was 4 years. The inclusion were more than 18 years in shock with systolic BP of less than 100. The study protocol was dose of noradrenaline and dopamine depending on the patient's body weight. The dopamine was increased at the increment of 2 micrograms per kg per minute till max of 20 mics per kilo per minute was given, and noradrenaline could be increased in the increment of 0.02 mics per kg per minute were on, and then the study drug. If the hypotension reoccurred, the trial drug was resumed, and on readmission to ICU within 28 days of randomization, the study drug was instituted. So the study period was for 28 days. They looked at the adverse event in the form of arrhythmias, myocardial necrosis, skin necrosis, ischemia of the limb, and the other treatment was given at the discretion of the physician. The primary endpoint was the death at 28 days, and the secondary endpoints were the rates of death in the ICU, duration of stay in the ICU, number of days without the need for organ support, time to attain the hemodynamic stability, time to reach a mean arterial pressure of 65, changes in hemodynamic variables, and use of dobutamine or other inotropic agents. So they had total of 1679 patients who underwent randomization. 858 were assigned to receive dopamine and 821 were assigned to receive norepinephrine. The baseline characteristics were similar in both the groups. They had majority of the patients had sepsis followed by cardiogenic and hypovolemic shock, and few were with the others. Their baseline, again looking at their cardiac index, PaCO2, lactase, the hemoglobin, creatinine, all the parameters were same in both the groups. What was different was the open-label norepinephrine requirement was more in the patients in the dopamine group. So the patients who were treated with the dopamine required norepinephrine on the top of the dopamine at max dose of 20 mics per kilo, and the dobutamine was given more in the patients with the norepinephrine group. The duration of the stay in the ICU, the hospital length of stay was not different, it was same. If you look at the Kaplan-Meier survival curve, there was not much difference between the norepinephrine and dobutamine. But what was different again in this significant was the patients with the vasopressor was not needed, as vasopressor free days was more in the patients with norepinephrine, and the open label vasopressors was used more in the norepinephrine group, and the renal support that was not needed. So the patients with the support free and the open label vasopressor free days were more in norepinephrine group, and the renal support was not needed more in the norepinephrine group. So this was statistically significant. And what was more significant was the incidence of arrhythmias. So the dopamine group had more arrhythmias as compared to the norepinephrine group. The other thing was not different, and when the forest plot was done for the predefined subgroups, what is definitely coming significant is in the patients with the cardiogenic group, the outcome was better with the norepinephrine, and this is contradictory to our traditional teaching saying that the cardiogenic shock should not receive norepinephrine and we should be using dopamine. But this study has clearly showed that in cardiogenic shock, norepinephrine should be the inotrope of the choice, probably because dopamine led to more arrhythmias and the more problems as compared to the norepinephrine. So in summary, this study showed that the rate of death did not differ significantly between the group of patients treated with dopamine or norepinephrine, and it seriously raises the concerns about the safety of dopamine therapy, since the dopamine as compared with norepinephrine was associated with more arrhythmias and increased rate of death in the subgroup of patients with cardiogenic shock. Thank you.